Reno-Vascular hypertension is a form of secondary hypertension caused by renal artery stenosis, a condition characterized by the narrowing or total occlusion of the renal arteries. This obstruction can occur unilaterally or bilaterally, and the body's compensatory mechanisms differ significantly in each scenario. In the case of unilateral stenosis, the reduced blood flow to the affected kidney triggers the renin-angiotensin-aldosterone system. The drop in perfusion pressure stimulates the release of renin, leading to the production of angiotensin II, a potent vasoconstrictor, and aldosterone, which promotes sodium and water retention. This biochemical cascade drives systemic blood pressure upward. Meanwhile, the healthy kidney is exposed to this high systemic pressure. It responds through a phenomenon known as pressure natriuresis, where it increases the excretion of sodium and water to compensate for the volume load. Over time, the chronically underperfused kidney undergoes atrophy, resulting in the classic asymmetrical kidney size seen on imaging. When both kidneys are affected, the clinical picture becomes more dangerous. Failure of compensation, while the RAS is still activated due to low perfusion. Because both kidneys are stenotic, the mechanism of pressure natriuresis is lost. This leads to massive sodium and water retention, causing significant intravascular volume expansion. This fluid buildup can eventually override the RAS signals, resulting in a volume-dependent hypertension. Complication of bilateral disease is flash pulmonary edema, as the heart struggles to manage the sudden, overwhelming fluid volume. Fibromuscular dysplasia, FMD, a non-atherosclerotic, non-inflammatory vascular disease. FMD is characterized by abnormal cellular growth within the arterial walls, most commonly involving the tunica media, the middle muscular layer. This abnormal growth results in three primary vascular issues. Stenosis, narrowing that restricts blood flow. Aneurysms, weakened areas that bulge outward. Dissections, intimal tears that allow blood to enter the vessel wall. FMD is a systemic condition, and the symptoms depend entirely on which vascular bed is involved. Renal arteries leads to refractory hypertension and, eventually, renal failure. Carotid and vertebral arteries causes cerebral hypoperfusion, increasing the risk of TIA or stroke. Patients often report pulsatile tinnitus, a rhythmic whooshing sound in the ear, or neck pain from dissections. Mesenteric arteries triggers mesenteric ischemia, where the patient experiences severe abdominal pain, often called intestinal angina, shortly after eating. Hope it helps. Thanks for watching. Subscribe for more.